We're going to go ahead and get started with the panel session, so I'm handing things over to Chuck, who is the moderator.
Good afternoon. You can keep eating, but I'm going to ask you to stop talking with each other. Be sure your cell phones are off. Thank you. So we have a panel today on the past, present, and future, or at least two of those of health economics. I gave you a few of my own thoughts on the topic last night at dinner. But we have Karen Davis, who is, I think actually, I'm not sure I should say this, but I will anyway. I think Karen and I met in health economics conferences before Amitabh was born. So we have a spectrum of perspectives here. Karen, I think, as all of you know, has been very high profile in the world of health economics and health policy for her entire career. She recently stepped down as director of a Commonwealth Fund major foundation in the field, and certainly with that podium, a major spokesperson for health policy for her time there and beyond, and is now a professor, endowed professor at the Bloomberg School of Public Health at Johns Hopkins. Amitabh, I didn't mention this last night, but he and I first met, I think, at the 1999 equivalent of this. It would have been the 10th anniversary, not the 25th, on a boat on Cayuga Lake.
That's right.
And I can remember thinking, that is one smart dude. And that has turned out to be a pretty accurate prediction. He is now a professor at the Harvard University, where it seems to be the magnet for almost all health economists in the country that are not at Johns Hopkins. Welcome to the two of you. We're going to have a presentation first from Karen and then from Amitabh, and then we'll be open for questions. I'm going to ask when we get to the questions that everyone speak up loudly. I'll probably try and summarize or repeat the questions because this room seems to swallow sound in a high capability. So Karen, why don't you take us forward here? I've seen Karen's slides in advance and I have eyes in the back of my head, so I'm in good shape.
Well, thank you, Chuck, for that lovely introduction, and to Vivian for welcoming me back to Rice, which is my home, having been an undergraduate, graduate, and on the faculty here. So great pleasure to be here, and a great pleasure to hear all of the wonderful presentations on key issues. Particularly excited about the research that takes advantage of natural experiments to learn from those interventions, and particularly excited about those that are trying to bridge the worlds of medical practice and economics by getting to some of the things that Chuck told us last night. He foresaw 25 years ago, more disaggregated research, more institutional knowledge, more understanding of the health system. So particularly looking at health outcomes like mortality and use of different types of services and prescription drugs. So all Vivian asked me to do was to cover the past and future of health economics research, but to stay within 15 or 20 minutes. So that seemed a bit daunting. And so I'm really going to focus primarily on research that informed the enactment of health reform in 2010, and focus a bit on what I know best, which was research funded by or conducted by the Commonwealth Fund. So I do think that we have had, over the last 30 years, a very rich period of health services and health economics research that has focused and helped us really better understand the problems in the health system. But beyond that, what are some of the solutions to reforming the health system that would yield better value? So I wanted to talk about that. I also wanted to spend a bit of time on the estimates that were made about health reform and the modeling that went into that, particularly with regard to predictions on cost and coverage, and then wind up with Vivian's charge to look at some of the future issues. So to keep it short, I try to say that research covered the major issues of the uninsured, cost of care, quality of care, administrative complexity. But I think it's important to think about what was the fertile ground that led to health reform. After all, presidents or presidential candidates, really since Theodore Roosevelt in 1912 in his run on the Progressive Party platform, proposed universal health insurance coverage. Why did presidents over that century fail? And yet this got enacted. And I think it particularly was precipitated by a major growth in the numbers of uninsured from 1999 to 2010, when it jumped from 39 million uninsured to 52 million uninsured, the rapid increase in healthcare costs over that decade, and actually an increase in out-of-pocket costs as deductibles also went up, as total health spending went up. But it was also precipitated, I think, by growing evidence that the U.S. was really not getting value for the money it spends on healthcare. And starting with the Institute of Medicine 1999 report, To Err is Human, followed by their Quality Chasm report, that the quality of care that is in fact achievable is not the actual care that we have, and a system that has a fair amount of waste and transaction costs that comes from the particular way in which we organize and finance care, including churning in insurance coverage, high administrative costs, particularly in coverage for individuals and small businesses, but also the administrative costs, for example, that physicians face dealing with all the different requirements of the different insurance companies for whom they are paid. So to focus a bit on research on the uninsured, the research over that decade I focus from 2000 to 2010, certainly documented that the uninsured weren't getting access to care, in their view, not getting care that they needed, not getting recommended care, not filling prescription drugs that their physicians had ordered for them, not getting follow-up tests, and that they were also facing financial burdens of medical bills and accumulated medical debt. And a lot of that research looked at those who were uninsured at a given point in time, those that were uninsured at some point during the year, plus those who were underinsured, spending, say, more than 10% of their income on medical expenses, or more than 5% if they were low income. And across all of those groups, again, finding much higher rates of difficulties with access to care and the financial burdens of care. Insurance documented that this was not only growing, but hitting the middle class, and not just an isolated problem with a few low-income uninsured individuals, but as many as 42% of all adults ages 19 to 64 falling into these categories of being uninsured, intermittently uninsured, or underinsured. A lot of research documented that whether you had coverage depended on the type of job you had, and in particular that large firms, nearly 99% of those with 200 or more employees covered their workers, but coverage was less frequent among smaller firms and less adequate, and certainly had much higher overhead and administrative costs. Furthermore, research documenting the skewness of medical expenditures made it clear that there was very strong economic incentive for insurance companies to avoid the sick, try to weed those out through various practices, particularly in states that didn't have protections on open enrollment, guaranteed renewal, community rating. All of this led to a fairly natural phenomenon of practices that made it very difficult for people with any kind of health problems to get coverage or get affordable coverage. The second part of research really had to do with a better understanding about trends in healthcare costs. I think a lot of us in the mid-1990s noticed the flattening of health expenditures, certainly as a percent of the gross domestic product, attributed that to managed care. If you look internationally, you see that most countries had a flattening in the 1990s, so more likely related to common issues such as technology. But where the U.S. really began to diverge was in the last decade, where whether you looked at it on a per capita basis or as a percent of GDP, the U.S. really began to pull away from other countries in the cost of care. I like to point out that the Commonwealth Fund was the first one to put both of those slides on the same page and stopping the discussion about which one was the right one. The other thing the Commonwealth Fund did beginning in 1998 was to start doing annual surveys, first of 5 countries and now 11 countries. They're actually on a 3-year cycle. One year the entire adult population, another year the chronically ill adult population, and on the 3rd year primary care physicians. So collecting comparable data across countries from these annual surveys, augmented by things like, for example, Ellen Nolte and Martin McKee's work on mortality amenable to medical care. But having comparative data on health system performance, over 65 different indicators in the domains of quality of care, access to care, efficiency, equity, and health outcomes, the U.S. in general ranked last on most of those indicators, particularly on those with regard to financial access to care, equity, and efficiency, as you see on the bottom row, with the U.S. spending roughly twice per capita on average what other countries spend on health care. And it changed the perception of the U.S. health system from politicians routinely saying the U.S. has the best health system in the world. Every time I heard that, I thought that's kind of a data-free statement. And I asked our international fellows at the Commonwealth Fund who had the best system, and everybody said their own country. So it is clear we're most comfortable with what we're most familiar with. But when you really look at performance, I think the view shifted that the U.S. spends more but doesn't get more for what it spends on health care. Aside from documenting the problems with the performance of the health system and the growing problems of adequacy of insurance coverage, research began to point ways in which we could move forward. The Commonwealth Fund set up a task force on the future of health insurance in 1999, which operated for about 6 years. It was chaired by Dr. Jim Mongan, who became the CEO of the Partners Healthcare. He also became president of the Boston Chamber of Commerce and was very influential in the Massachusetts health reforms in 2006. Another member of the task force was Kathleen Sebelius, who was the insurance commissioner from Kansas. So by picking people who became quite influential in health insurance nationally, at the state level, at the healthcare delivery system level, it helped inform them about effective solutions for change. One of the early reports of the Commonwealth Fund in 1999 focused on young adults and high rates of uninsurance among young adults, the health consequences of that, and developed proposals to cover young adults under their parents' health insurance policies. So if anybody has health insurance through their parents, you can thank that work. And states began to do it, but obviously it's a major provision in the Affordable Care Act. In 1984, the Fund put out a report published in Health Affairs called Creating Consensus that showed that it was a fairly practical way to get to universal coverage by expanding existing sources of coverage, including Medicaid and the Children's Health Insurance Program for those below 150% of poverty, expanding Medicare, for example, eliminating the 2-year waiting period for the disabled, expanding employer coverage by requiring larger firms to cover their employees, as most did, but also setting up a health insurance exchange for individuals and small businesses modeled, for example, on the Medicare Advantage a marketplace exchange that we heard a lot about yesterday, with a public plan and various private insurance options competing under rules that level the playing field across those choices. That was published in 1984. Senator Kerry adopted the proposal, as did other Democrats, and really laid the foundation for the Massachusetts health reforms in 2006. We followed that up with a commission on a high-performance health system in 2005, again chaired by Jim Mongan, and put out this building blocks article in Health Affairs in 2008, and again had it adopted by, at that time, candidates Obama and Hillary Clinton, along with cost and coverage estimates. So it kind of shows the value of work, even when things aren't happening, of continuing to get ideas out there and helping people understand what's feasible to do and what the implications are. The Commonwealth Fund also, I think, really emphasized that the issue is broader than just insurance coverage. Part of the problem in the past is people who had insurance didn't see that they could gain anything from moving to universal coverage, and kind of sensed that they might be disadvantaged by that. But by focusing on ways of improving the delivery of the healthcare system, making services more accessible, giving people improved benefits who felt vulnerable to out-of-pocket costs, more people gained. But with the establishment of our Commission on a High-Performance Health System, we gave them the charge of coming up with win-win-win solutions that would simultaneously lead to better access, improved quality, and greater efficiency. And the Congressional Budget Office had, for a number of years, put out a report called Options for Reducing the Federal Deficit. But it was focused very much on the federal deficit. So there would be options like increasing the Part B Medicare premium would reduce the federal deficit because Medicare beneficiaries would pay it, and it would move it off of the federal budget onto beneficiaries. But what the Commission did is focus on total health system spending, not just shifting it from the feds to the states or from employers to individuals, but what would the effect of policies on total health system spending, and put out a report in November of 2007 called Bending the Curve, which is the first time anybody had ever heard of that phrase, and it became just kind of a mantra. Are there things that we can do that will simultaneously reduce total health spending while also improving access to care and quality of care? And then followed that up in February of 2009 with a more detailed reform proposal called the Path to a High-Performance Health System. And it was just at that point that President Obama said to the Congress, I'm not going to develop my own proposal, you come up with a proposal. So they kind of looked at each other and thought, well, here's something that we can build on. So from kind of strategies for expanding insurance coverage to ways in which payment and delivery system reform, such as bundled payment to reduce incentives for hospital readmissions, were built into it. And again, estimating what the impact would be, showing, for example, if we stayed on our current course with health expenditures increasing at 6.7% a year, we'd be at $5.2 trillion by 2020, and showing that there was a way to reduce that by investing in some of these system transformation on payment and delivery system. We weren't optimistic enough to say it would lower health spending. We understood that, as you covered, we were optimistic to say it would lower, but not down to GDP growth. So we still projected increases in health spending as a share of the economy. And we showed that there would be a bump up in 2013 as more people got coverage and the uninsured began to use services. But in fact, what has happened is that health spending is now below the growth in GDP. So even laying out that there was a way to do this, the reality has been much lower spending. We also noted the waste that it incurs, particularly in the individual and small business market, with a very high share of the premium going for administrative costs. And one of the provisions that was implemented to address that was capping administrative overhead at 20% in individual and small businesses through and offering the health insurance exchanges. David Cutler at Harvard and I began to look at some of the Congressional Budget Office and the HHS Office of the Actuary projections, and kind of sounded a warning as early as May of 2010 that CBO was being too conservative in estimating savings from health reform. Particularly, and I think it's relevant to what we've heard today, they were very unwilling to give any savings for incentives for physicians to change behavior. It was much easier for them to look at cost sharing as that was reduced, how it would increase use of services, but much less comfortable with looking at savings from payment and delivery system reform, and even giving very few savings from greater competition through the formation of health insurance exchanges. Noting that savings in the Medicare program, our estimate was that it was closer to $700 billion over 10 years instead of $500 billion. In 2012, CBO said, oh well, it's $750 less than what we projected. But the real shocker to me, and this is kind of a dirty little secret that nobody talks about, is that CBO made a little $1 trillion mistake in the projection of Medicare spending between 2011 and 2020. What they projected would happen pre-reform and what actually has happened post-reform. They thought it. So I think all of us have a vested interest in understanding why they were high, projecting both national health expenditures and Medicare coverage, and thinking about what can be done to address it. Certainly, CBO and the Office of the Actuary said, well, they didn't estimate the effect of the Great Recession, couldn't have anticipated that. But it's hard to see exactly how that would have affected the Medicare estimates as much as it might have for those under 65. And I would posit the following reasons. One, that they're wary of underestimating the cost of any new proposals. They were soundly criticized in the Medicare legislation with underestimating the cost, and they feel like nobody's going to scream at them if they say it costs more than it turns out to cost, but if they underestimate the cost, and Congress has to make up the difference. So there's a built-in bias toward overstating costs and understating savings. John Cable, in fact, did a study for the Commonwealth Fund that looked at estimates by CBO for three major changes: the DRG legislation in '83, the Balanced Budget Act in '97, and the Medicare Modernization Act, or prescription drug, in 2003, and found that they were off 50 to 100% on cost or savings under those three major proposals. So it's not the first time. Gable emphasized the synergistic effect of multiple interventions, that things work far more than one thought they would when you combined multiple initiatives. And certainly health reform had some thought, throwing this kitchen sink at the problem. Every idea that anybody had managed to find its way into the legislation. But I would also stress that they're most comfortable with demand elasticities on health care and health insurance coverage. So how a tax, like the Cadillac tax, on excess health insurance premiums would affect coverage, or how increased cost sharing would affect cost, than they are with supply side, so that they actually give very few savings, and they have very little knowledge of the actual factors that are going on in the healthcare system, the institutional structures that do affect their projections. So the real implication of being off by $1 trillion is that under the budget rules, all of the spending under health reform had to be financed. So over 10 years, the cost covering the uninsured was estimated to be $1 trillion. Half of that from Medicare savings on Medicare Advantage and provider payment changes, and half of it from increased taxes. Now we see that Medicare alone has achieved $1 trillion worth of savings. And I said at the time on the CBO Health Technical Advisory Committee, we'll never see this table again, because the revenues kind of get hidden. So if there's increased income taxes on high-income individuals, it just goes into the income tax revenue. You don't see the little piece of it that comes from health reform. So we will see the spending side, so we'll see the subsidies, but they're bound to be less than what's projected for 2 reasons. Healthcare costs are a lot lower than was assumed when the estimates were made, and there are fewer people getting covered because of the Supreme Court decision on making Medicaid expansion optional for the states. So instead of $1 trillion, who knows, maybe it's $750 billion. At some point we will know what the actual numbers are for that 10 years. Meanwhile, we've got $1 trillion from Medicare and at least $500 billion coming from all of the taxes that were also embedded in the Affordable Care Act. So when you see the deficit numbers for the federal government coming down, it's like the health system again gave, as they did with the Balanced Budget Act, by generating revenues that actually benefit the rest of the federal budget. So I do think our credibility as a profession will go down if we can't get closer on these estimates. The other one that I like to cite is the estimates that both CBO and the Office of the Actuary made about the effect of Medicare Advantage. This probably was the most important political issue with regard to health reform, that seniors were told that Medicare was being cut and the savings used to cover the uninsured, which made many seniors very hostile to health reform. And the one piece of that was that Medicare Advantage plans were paid 13% more than traditional Medicare, and the legislation phases that, so eventually they'll only be paid about 1% more than coverage under traditional Medicare. What CBO and the Office of the Actuary estimate is that that would lead to a 30% drop in enrollment, that plans would drop out, that people would face increased Medicare Advantage premiums or reduced benefits. Again, if you look at, since then, of course, enrollment has continued to grow. If you look at what CBO says now, they're basically estimating twice as many people will be covered by Medicare Advantage in 2020 as the estimated during reform. So again, a huge difference, and it's still kind of a major political issue, even in campaigns this fall. So why were they wrong? I think partly it's that Medicare Advantage plans were highly profitable, and they continue to be profitable, but somewhat less so. So why would any business really pull out of that market? Learning more how to get better modeling, get better projections, I would put high on the agenda for future research. In my view, great research is research that addresses an important problem. So if there's any takeaway I could leave with this next generation of health economists, is to pick the most important issues of the future to work on. Obviously, as a funder of research, we wanted to fund research that would answer issues 2 or 3 years down the road, not today's immediate problems, but those coming up in the next anywhere from 2 years to a decade. I think analyzing the long-term impact of the Affordable Care Act, I think many would say the jury's still out on whether this abatement in healthcare costs is real and will be sustained, or it'll go back up as it has many times in the past. The second has to do with the extent of the subsidies and the comprehensiveness of benefits. And particularly for people in the 150 to 300% of poverty level, I think many would say coverage is still leaving them with unaffordable options. Another major issue is this fragmentation of coverage. We've got Medicare for the seniors and disabled. We've got Medicaid and the Children's Health Insurance Program for low-income people. We've got the health insurance exchange marketplaces for people who don't have coverage through their employers. We have employer plans. And so I think a major agenda for research is really looking at the performance across those different systems of coverage and learning from what ought to spread as best practices or how to bring some of them into greater alignment and realize greater leverage and lower administrative costs. So however one assesses performance, whether it's satisfaction of enrollees with their care, access to care, financial protection, cost control, administrative costs, a whole bundle of research that's needed on that. The big issues that weren't really addressed by health reform are provider payment. Obviously, there's a lot of innovation going on with the Centers for Medicare and Medicaid innovation, but we really haven't moved away in a fundamental way from fee-for-service payment, but we'll be learning a lot as those experiments unfold. We also haven't addressed Medicare. Medicare spending on a per beneficiary basis is now well below the rate of growth of GDP per capita, but there are a lot more beneficiaries coming online as the boomers age into Medicare, which will lead to even more increased pressure on that program. And obviously, the issue of long-term care hasn't been addressed. Even the modest provision, the Class Act that was in the Affordable Care Act was removed. So lots to work on, but those are major issues for the future, and many thanks to my colleagues.
Thank you. Good thing. Thank you. While they're setting up Amitabh's slides, Karen and I were talking yesterday about this misforecast of the Part C Medicare Advantage enrollment, which puzzles me also. My conjecture there is that if you look at the age profile of people that are picking up Part C, it's mostly new entrants into the Medicare system. And so what I suspect is going on, Karen, this is total conjecture, is that people are moving out of the employment base and basically they find they can pick up insurance that's look a lot like what they had when they were employed. And so as you phase that group in, and all of the older generation of Medicare enrollees are in Part AB, traditional AB, I think I'd expect to see that continued growth in the Part C enrollment, and Medicare Advantage enrollment, just because people are staying with what they're comfortable and familiar with. So that's my conjecture is what's going on. Amitabh, you're up.
Thank you, Chuck. Thank you for those terrific thoughts, Karen, and to Vivian for inviting me back to Rice. Karen and I agree on just about everything, so what I thought I would do is take this conversation in a slightly different place. I want to pivot from where she left off, which was to talk about how we can improve the quality of work that we do for policymakers, and try to talk a little bit more about the kind of research that we do in the journals that we spend all our time writing. So I'm wearing two hats. I'm wearing a hat as a professor and an economist at Harvard University, and I'm also wearing my hat as the chair editor of the Review of Economics and Statistics, and I can share with you what happens to health economics papers when they come to Restat. So of course, the big thing and the really exciting thing about economics and health economics is it is what we do. So in terms of what is the future? The future is really what we make of it. If you look at what's happened to development economics over time, it's really what economists did to development economics, which has made modern development economics what it is. What I want to talk about insofar as the future of health economics goes is the fact that at the end of the day, I think that what we'll end up producing in health economics in the years to come will be defined mostly by the constraints that we confront as researchers, as well as the incentives that we're working under. So I'm not talking about the policy research that Karen's talking about, as much as the sorts of papers that we would write for journals like Restat or the QJE or the AER or the Journal of Health Economics or journals like JAMA in New England. And my argument is that that kind of research that we do will be affected by both constraints and incentives. So let's talk about constraints and incentives. So in terms of how things have been going for health economists, things are great, right? So like you open up Joe and you look at the number of health economists that people want to hire today in the 2015 job market and contrast that to 15 years ago. And it's really extraordinary to see the extent to which policy schools, arts and sciences departments, business schools, policy schools want to hire a health economist, right? So that's really, really exciting. In fact, I think what's interesting to watch at Harvard is the demand for economics and health economics is so large that we now have social epidemiologists teaching classes that are titled behavioral economics. Like these guys don't know anything about economics or behavioral economics, but they're teaching a class titled behavioral economics, which is sort of a way to say you're an economist without knowing any price theory and then sort of share all these little twiddles that we have. But there's a lot of demand for that. But again, I think we should be the ones teaching those classes instead of having those guys teach those classes.
Don't you have truth in advertising laws at Harvard?
No, we don't. And we're not a union either. So because we're not a union and there are no truth in advertising laws at Harvard, you can see how all this entrepreneurship proliferates. Health economics is also ground zero for collaboration outside of economics, I think. So if you think about who health economists collaborate with, and compare that to who IO economists, or conventional IO economists or macroeconomists collaborate with, health economics is really ground zero. I mean, so you look at, who does someone like John Skinner collaborate with, and you'll see a roster of people from different disciplines. They'll come from sociology, they'll come from cardiology, they'll come from social epidemiology, and they'll come from different parts of economics. And I think that's true, uniquely true, of this subfield of economics. And then as Karen pointed out, the influence in public policy is sort of unparalleled today. So I remember I was trained as a labor economist. I went to Dartmouth. I started working on health economics. And people, even back in 2002, would say, what do you work on? And I said, I study cost growth and Medicare. And they said, well, why don't you work on something important? That was 2002. But now it's all in the air. And that wasn't true 15 years ago. And I think what's happened is, because of the terrifying budget situation, we have become the new macroeconomists, right? So if you go to the big Fed meeting in Jackson Hole in August, and you watch the parade of sort of international finance people like Ken Rogoff and Raghu Rajan and Marty Feldstein, in there is Kate Baker talking about the federal budget situation, and all eyes are on her because of healthcare spending, right? Like the macro guys really don't know about what to do about that, but they do understand the tax implications of growing healthcare spending, particularly in the Medicare and Medicaid programs. And so I think because of all of this, what you also see is you see us teach people who are not economists. So if you go to Harvard Medical School, or you go to Penn Medical School or Stanford Medical School, you've got economists teaching non-economists. And I think that is very good for non-economists' appreciation of economists' methods. So you can see that diffusion in the journals of non-economists. You see IV papers in sociology journals and epidemiology journals. And this is terrific, right? This is the kind of imperialism of as a profession, but it's also respect for economists at the end of the day, because at the end of the day, many of the non-economists realize the benefits of collaborating with economists, and so they stop saying bad things about us. So all this is really, really good for us. But what has not changed for us, and this is the constraint, is that the conventional academic outlets have really not changed. So if you look at where you would publish conventional economics papers, right? It's the AER, the JPE, the Journal of Health Economics. We have the AEJs and restats, but it's not like there's an AEJ for health economics. And if you look at health services research journals, right, there's JAMA in New England and Health Services Research and Medical Care and Health Affairs. They were all around 15 years ago. So there's all this health economics happening, but there's an incredible constraint in terms of where you can publish the really, really good stuff. And that's a constraint that one wants to be aware of at the time of producing the research, because you don't want to produce research that, at least as an untenured faculty member, does not have an outlet. Okay? So I think the one theme that I'm going to talk about is this theme that I want to introduce now, is that these two outlets are actually very, very different. The audiences are different, the review process is different, the impact is different, and they actually have they require very different production functions. So one of the things that I would like to push you on, just like Karen pushed the group to think harder about more policy relevant research, one of the things I want to push the group on is to think harder about those of us who are trained as economists. How can we sort of colonize other disciplines more by pushing more economics into the health services journals and sort of making them economics journals over time. To do that, we're going to have to basically change the way we write and accept and understand how these journals operate and rewrite our papers for those journals. And I think that there's great appetite for economics papers in those journals as long as we write them the way they want to be written. Okay, so let's go inside the black box a little bit. So economics journals, again, this is where we've not seen a whole lot of growth. Restat, for example, we still put out 4 issues a year. Our acceptance rates are now down to 6%. We're rejecting papers that 5 years ago would have gone to the AER and the QJE. And I've rejected, I look at papers and I'm rejecting papers where you literally have a referee report saying, this paper is amazing. I would have been privileged to write this paper. You have comments like that coming in, and often these papers get rejected just because of the intense competition for limited journal space. It is also an extremely long, tedious process to write papers for leading economics journals. Even if one has sort of the technology of some, John Gruber or Amy Finkelstein, I sort of think of them as sort of the frontier producers in terms of speed. 1 to 2 years is how long those papers take to write. Another year for review if you're going to a fast journal. And then we all know what the bar is for acceptance at a top 5 or top 10 economics journal. Everything has to be perfect. And that's a very, very high bar. Now, health services research journals, you could produce a paper in a month if you have the right kind of X and the right Y, and you regress the two, and you negative correlation, positive correlation, you can toss it in there and say, well, it's an association, it's not causal. And so that gives you the ability to produce many more papers quickly. New England Journal of Medicine, guaranteed review in 2 weeks. So it's incredibly fast. You send something to the New England Journal, they're going to get back to you in 2 weeks. They'll get back to you in 4 to 6 weeks if it's going to be a revise and resubmit. Their review process is very different. It's up and out, and that's something that economists do not understand. We don't understand up and out reviews, meaning basically at New England Journal or JAMA, if you get revised and resubmit, it basically is almost like a conditional contract, right? They're not going to say, gee, if you do these 16 things, we're still going to reconsider, right? So it's a different production function. Different objectives too. They love press, so when they read, at the New England Journal's editorial board meeting, they'll spend a lot of time talking about, well, what's the New York Times going to say about this article? Which at Restat, we're never thinking, what is the New York Times going to say about this article? In fact, if we found out the New York Times was going to write something about that article, we'd be like, oh my God, are we sure we want to print this article? Right? Okay, health services research journals, the reviewers are different. They want simplicity. The argument has to be graphical, incredibly transparent. You can't show up with the GMM model. It might be the right model, but you're dead on arrival, like if with the GMM model, or even with the difference in difference model that isn't graphical, it's a dead on arrival kind of decision by the journal. It has to be accessible to practicing physicians, and policy relevance, the kind of work that Karen was talking about, is really rewarded in health services journals. They're very interested in papers that actually take on a policy problem today that we know will go away tomorrow, but your paper answers this policy problem today, and the journals will look at that. And at Restat, or at most leading economic journals, that's not going to happen. Reviewers are going to say, this is a paper about the implementation of healthcare.gov. This is not really going to be a paper with a long shelf life. Let's reject this paper. The final thing about health services journals is that they do reward facts. So economists often complain that economics journals don't reward facts, which is true, but health services journals do. So if you have a fact and you believe your fact, so it's not an association, it's just a fact, then think about sending it to a health services research journal because they will publish that fact. In that sense, they're far more intellectual than the economics journals because I think their view of knowledge is that it's really cumulative across hundreds and hundreds of papers, whereas our view of knowledge is that a single paper has to both produce the fact, explain the fact, and deal with all the alternative interpretations for that one fact. So we're looking for a very vertically integrated product, and they're actually very happy with like a specific fact. I want to give you an example of this. So this comes from a paper that I wrote, and this is just an example of sort of what kinds of facts they will take. So, you know, medical malpractice is sort of one of the big topics that physicians love to kind of talk about, especially here in Texas. Like, you give a talk on healthcare reform and you don't talk about med mal, like, you know, it's all over. But not much is known about how often doctors get sued. So you just don't know because there's no national database. So there's all kinds of stories out there about, oh, my uncle, he's a cardiologist in Houston, he got sued 3 times last week, and his son is a cardiologist or an orthopedic surgeon in Austin, and he was also sued, and Texas, really, everybody's getting sued all the time. You know, there's a lot of narratives like this, and nobody knows how often doctors are getting sued because there's no database. So what happens is we're hanging out in an airport lounge in LAX and grumbling about this. So this is a bunch of economists. It turns out the guy sitting next to us is the CEO of the largest malpractice insurer in the United States. And he says, I heard your conversation. I'm, you know, CEO of this company. I insure something like, you know, hundreds of thousands of physicians. I'll give you my data as long as you just refer to me as the largest malpractice insurer in the United States. So we were like, we have a deal. So we wrote this paper, and this is a paper written by economists in the New England Journal of Medicine. And this is an example of impact, right? So this is an example of a paper that has no economics in it. Let's be clear. This is a fact without economics. Within days of this paper appearing, it had 118 citations, right? This is the New England Journal, so like the impact factors are like 56, right? And what this paper contains is this graph. This is the graph that basically shows you that, you know, discipline by discipline, what is the probability of a physician being sued? So if you're in neurosurgery, you're likely to be sued about 19% of the time. This is the annual probability of being sued. If you're in pediatrics, it's about 3% of the time. That is the paper, right? That's it. There's no model, there's no speculation, there's no theory, there's no policy. It is a fact. But it's a deeply, deeply important fact for policy, for economists writing other papers on defensive medicine, and for doctors. And it's the kind of paper that, you know, only an economist would have produced because we sort of know that this fact is not known, so we grumble about it. The physicians are quite happy telling you what happened to them yesterday, so they're not going to be looking for, you know, sort of a way to sort of systematically document the fact, but this is the right outlet to put the fact into. Now here it gets better. So we took this data set and then we wrote another paper in the New England Journal of Medicine. So this is a different paper, right? And it just shows you area of medicine by area of medicine what the average defense costs are. So in cardiology, for example, to defend a claim, the average cardiology claim costs $80,000 to defend, right? So this is a separate paper. This is what I mean by how in medicine you could actually take your and here's a third fact. This is a different paper. Is sort of how long do these claims take to be resolved. So if you look at the blue line, that's basically your fatalities and permanent injuries, and it's basically saying even 3 years out, 20% of these claims have not been resolved. Look, we're not saying anything about whether you should reform or not reform the malpractice system. We're just literally putting out 3 facts, right? And I think this is very, very valuable. It's certainly valuable for your CV because you get citations. It's valuable for the economics profession because, you know, ultimately you can't do theory in the absence of facts, right? It's important for policymakers because, you know, the importance of all these different policies really turns on how prevalent the underlying malpractice is happening. But our journals, like Restat, Journal of Health Economics, this would be dead on arrival. Even if I took all 3 facts and made them one paper, called it Facts on Malpractice Insurance, Joe Newhouse would probably reject my paper saying, this is not an economics paper. And I think he'd be right, but there is this other outlet which requires a completely different style of writing. And I think it's worth thinking about that other style of writing because it's really good for our profession as we start to push our kind of, you know, fact collection or empirical work into these journals because we start to change the standard in those journals. We start to become part of the editorial boards of those journals. And over time, we've essentially co-opted one of those journals and made it like a health economics journal, which is what we should all be doing. So what should you be produce? What should you be producing? So I think what you should be producing really depends on where you're sitting. So it's very hard for economics departments to value these non-economics journals that I've been talking about. So when I was at Dartmouth in the economics department, this is a highly interdisciplinary and collaborative department, but even then, I was told that papers in New England Journal and JAMA were a hobby. They were as good as playing the piano. They said it was a nice to have. That was an actual comment. Like, we don't really care, Amitabh, if you're a great pianist or you have a paper in JAMA. Both of them, neither of them are economics. I was told it was stamp collecting just because you're not theorizing, you're just collecting facts. Medical schools and schools of public health are far more familiar with these non-economics journals and the JHE, but they're a lot less familiar with AER and the QJE. Now, I think what's interesting is that the set of people who can hit in both journals is very, very, very small. So if you look at the guys like John Skinner and Doug Steger, I mean, I think of the two of them as really being the only two economists who can sort of repeatedly move in and out of like the QJE, the AER, and NEJM on a regular basis. You can find exceptions. It's really, the reason for this is not some special aptitude that they have, other than the fact that they're humble. What they have taken the time to do is they have made the investment to write the article for JAMA or New England using the rules of JAMA and New England, which is something that economists never do. Economists love to take the article that they wrote for the AER. Somebody tells them you should send it to New England Journal, so they'll take table 1 and 2 from the AER paper that got rejected, send it to the New England Journal where it is dead on arrival because, again, they want graphs, they want simplicity, they want transparency, they want you to take your 3 facts and make it 3 different papers. But if you figure out what those rules are, they're not that hard. You could have 2 very successful research programs which would benefit you, but would also benefit the health economics profession. So here's an example of the kinds of things that go on in medical journals that economists refuse to sort of engage with because we're right and they're wrong. But nevertheless, our unwillingness to engage with sort of the rules that another discipline has put together often means that we get rejected. So, you know, medical journals love logits. We're like, hey, just do a linear probability model. Of course we're right? Like, if I just want the conditional mean, do the OLS. You're not going to win that battle with a statistical reviewer at JAMA. They're going to say, don't do random effects, do hierarchical linear models. And we'd be like, well, come on, asymptotically, they're the same. But you're not going to win that battle with the statistical reviewer. They love to report odds ratios and hazards. And we would say, oh, I don't know what an odds ratio of 3.1 is. Just tell me the change in percentage points, which is true. But again, like, that's not the language that they speak. So if we just took the time to be a little bit more humble, we could actually do great things for ourselves as well as for the profession. So in terms of the future, where are we going? I don't really have this view that like we can create research on hot new topics. My view is that like it is what people decide to do. There are a number of questions that are hot right now. That doesn't mean that they'll be hot tomorrow. On productivity dispersion in healthcare, on competition on exchanges, we talk a lot about provider competition, but I think one of the things we've learned from Lee Moore Daphne's work is just as important is the fact that you want a ton of competition on the exchanges, because if you have a monopoly in the insurance market and a monopoly in the provider market, the combination of 2 monopolies in a geographic region is really lethal for consumers. And very contrary to the health services research view of competition, which is something like, oh yeah, we have a really big hospital system, so we need a really big insurer to negotiate with that really big hospital system. That's like terrible economics, right? Like, because why would the really big insurer pass on those lower rates to consumers in that region? I mean, it might happen, but that's like a funny model from the usual models we write down. So anyhow, so I think there's a lot of work we can do on delivery system reform and optimal plan design, and there's appetite in the journals for this. But I think the reason is not only the policy relevance, it's also that, you know, the old ideas in economics, like on supplier-induced demand, on what's the causal effect of insurance on outcomes, you know, what's the effect of plan design on utilization, old questions. But if you have great data, simple economic intuition, crisp identification, this paper is going to the QJE or the AER. I mean, I think the journals are still hungry for that kind of work, and you have the added bonus of transforming policy as well. This is an example of something I did that I have a lot of success with. This is productivity dispersion in healthcare. Each blue dot is an American hospital, and what I've graphed for you is performance of 3,690 American hospitals on heart attack treatment. So on the x-axis is 1 year spending, on the y-axis is survival. This is like a lot of the work that comes out of Dartmouth. You can see hospitals range in 1 year survival from 62% all the way up to 76%. And on the x-axis is how much stuff they did to their patients at 1 year. And the red line is the line of best fit, right? So that, if you've never seen 0 before, that regression coefficient is 0. Now, what would non-economists do if confronted with this graph? They said, just like my friends and co-authors at Dartmouth said, look, what we need to do is we need to cut medical spending. So cut medical spending from here over there. Now, of course, there's nothing in this graph that tells you that if you cut medical spending, somehow this cloud of low-performing hospitals, which are low survival, high cost, will like move to becoming this group of hospitals, which is high survival, low cost. There's nothing in this graph that tells you that. And yet, there's a lot of appetite for this view that like, because there's some productivity dispersion in healthcare, it is possible to cut medical spending and extract that waste out of the system. So one of the things that Steger and I were able to do was to argue that rather than sort of have this flat of the curve view of healthcare, which has been popular with the non-economists, an equally powerful view of healthcare, this is the flat of the curve view, right? Cut money, cut spending in Los Angeles, it'll become Minneapolis. Totally different view is, look, Los Angeles and Minneapolis have totally different production functions in how they produce healthcare. You cut spending in Los Angeles, you get crappy Minneapolis. You don't get Minneapolis at all. And so then the key question becomes, how do you actually move from one production function? How do you generate that TFP shock in Los Angeles to produce Mayo Clinic style healthcare? But that is not about cutting money. That's about a whole set of other interventions. Now, how do we get from the flat of the curve model to this model? The flat of the curve model has a very simple economic prediction in it, which is that if you were to look at the marginal benefit of doing more in Los Angeles, it should be lower than the marginal benefit of doing more in Minneapolis. That's actually testable. Empirically, we found something very different. We actually found that the marginal rate of return to doing more in Los Angeles was higher than the marginal rate of return to doing more in Minneapolis, even though overall outcomes were just the same. So teeny dose of economics. I mean, this is not even intermediate micro. This is sort of, this is sort of like a non-economist who sort of was, had a little bit of economics would come up with this argument. You use a little bit of economics, you'd go test it, you get an insight, and then you get a transformative fact or interpretation which can transform the policy debate overnight. I think that is really the comparative advantage of economists. So let me just continue with this. In terms of the big unanswered question, so again, I'm not talking about the policy questions, but from a pure research point of view, my own sense is that if you look at the work we're doing in our journals versus the work that people tell us to do, legions of health economists have told us that the underlying driver of cost is new medical technology, right? And yet we keep writing these papers about everything but medical technology. And so I think much more work on, how does innovation and discovery hazard deep in the bowels of Novartis or Bristol Myers Squibb? How does a pharmaceutical company decide whether to go for a phase 1 trial or a phase 2 trial in nivolumab versus some other compound work? We've done very little work on sort of studying those kinds of things. We've done very little work on understanding how right the FDA get the speed safety trade-offs. I mean, there's work on this, but relative to the importance of the question, there's very, very little work. There's very little work on the linkages between profitability and innovation. So there's the Asimoglu and Lin kind of work that I think is the best work on topic. But again, what we're really interested in is not, does more profitability cause more innovation? I think the answer to that is yes. But does more profitability cause more marginally useful innovation? So that we know very little about. And that requires us to assemble big data sets and things like that. We know very little about the relationship between supply-side incentives and care delivery. Now, one reason that, as Karen said, we spend a lot of time thinking about the demand side at CBO is because the evidence base for demand-side interventions is so much stronger and better than it is for supply-side interventions. On the supply side, we basically have a bunch of really crappy OLS pictures that say regions with more per cap, primary care physicians have lower outcomes. Well, that's neither here nor there, right? So what we want to know is the causal effect of producing one more or helicoptering one more primary care physician into a hospital system. And that requires a very different design than these OLS graphs that we use to do policy work. We know very little, I think, about the role of training. So if someone was trained as a cardiologist at Methodist over here down the road versus at Duke, how does that affect their long-term surgical signature? I think that we've got a little bit of work on this, but there's a lot more that could be done, again, relative to the importance of that question. So I'm going to stop over here and just sort of end with two thoughts. The one thing I would urge you not to produce if you're untenured is don't do policy boosterism while you're untenured. I think it's very, very costly for your reputation. It's not only costly for your reputation, it's also costly for your CV, because policy boosterism it takes a fair bit of time to do. It's often not done right because it is boosterism at the end of the day. And basically some other economist will come after you very quickly because there's always an economist on the other side of the aisle waiting for you to do your boosterism. So I think if you're interested in doing the boosterism, wait till you get the tenure and then do the boosterism afterwards. So I'm just going to close with these 4 points. I think in terms of this is sort of advice on a personal note on the research front, be scarce. So what that means is don't write papers that other people can write. Like if there's a fact that someone else could have produced, then you probably shouldn't produce that fact, because people will read that paper and say, nice fact, nice paper, but someone else could have done it. So your innovation should really be to work at that intersection of economics and health where other people find it difficult to work on. So in other words, don't write papers that a lot of other people could do. It does require very deep investments in data and human capital. So you do need to sort of spend a lot of time acquiring novel data sets and learning the underlying medicine. But I think the payoff is enormous. Economics as a discipline shines when we present trade-offs to policymakers. It doesn't actually shine when we just produce facts. So I encourage you to produce facts, but when we document trade-offs, that's when I think we do our very best work. And given what we're doing as a country on expanding here, cutting there, it's really now is the best time for us to be health economists, because very few policymakers have knowledge of the trade-offs that we are expert at producing. So my view is, it's no surprise that we're the new macroeconomists, because at the end of the day, we're the only ones armed with trade-offs. Of course, it helps to be standing on the shoulders of giants as well. So thank you very much.
So I need a bit of advice from the program coordinators. We are at 12:46 and we're supposed to have ended at 12:45. 6 more minutes. I'm going to take 1.5 of those with a couple of comments on what we've just heard. First, thank you to the two of you for these both quite distinctively different and both wonderfully illuminating presentations. I would have 2 quick thoughts. First, to tag on almost the last slide that I want to talk. One of the things you shouldn't do until you get tenure is try and create novel data sets. I've urged before to try and dig into more and more refined data. Wait till you have tenure. It's like you don't want to plant an asparagus patch until you have tenure, because they take 4 years to grow. The same is true with creating novel data sets. Pick them up and find them and use them, but don't do original data production until you have tenure, would be my advice. The one thing I did not hear talked about in these presentations, and I've not heard any papers today, and the one thing that I think is perhaps the most scary to me as I look into the future about our healthcare system, is the combination of the growing age profile of our population and the higher density of chronic diseases in the aging population. We have no idea how to compensate and pay for, provide incentives for production of good chronic care, and it's going to dominate our healthcare system in the future. I'll be very blunt about this. The fee-for-service system has its pluses and minuses. Almost all of the fee-for-service system's features in chronic care are minuses. It's not just a bad system, it's perverse in many ways for dealing with chronic care, and you can't apply comfortably the kinds of models of prospective payment that we've used in hospitalization or annual capitation in chronic care. So if you wanted what I think is the fertile area for imagination, it would be try and find compensation methods that work for chronic care that are somewhere outside of the realm of either hospitalization-linked events, which we know how to do, or annual capitation, which we know as HMOs. Is there anything in between that will help organize people to do chronic care better? And that would be the one topic area that I would add what Karen and Amitabh have suggested to you. So we'll have very brief questions. I'll ask you to make a question and not a statement. And please go ahead, Galfa.
Both talks, so I'll just make that statement. But I have a question for Amitabh, which is that I think one thing you didn't address with health services journals is that, you know, some papers can be like yours, which are simple, fact-based and stuff, but other papers are just poorly identified economics papers. And it's a hard thing to do when you're trying to send a well-identified paper there, because there's some sort of commingling where people aren't going to be sure that your paper is well-identified when you're competing with poorly identified papers where they haven't taken the time to do that. And it's not one of the review criteria, is what I've seen. Good identification is just not something that people in those journals are as sophisticated about as econ journals. And I wonder what you think people should do about that, or we as a profession, and especially as a senior person, speak to the senior people here. What can we do to transform them, to make them better identified?
I think we'd have to colonize editorial boards. That's my long-term strategy.
Yeah.
In the short run, I don't think you should be sending your well-identified paper to a health services journal, because you're constrained to 2,500 words and 5 exhibits at JAMA New England. And our papers are complex. It's not just the identification. The insight is often a non-trivial insight. And it's going to get hammered in a your paper will not shine in 2,500 words. So my view is either keeps, hopefully, like, no one should be writing the badly identified paper. Just like enjoy time with your friends and family, and if you don't have a family, make a family. Like, that is much higher utility, social utility and personal utility than writing a badly identified paper. The bad papers take as much time to write and make it through review than the good papers. Everybody knows the bad paper at the time of writing tenure letters. Just don't write them. Just work a little less. Write the good paper in an economics journal, or the simple fact or the elegant little paper for a medical journal. But gradually, I think the goal is we want to start to take over health services research journals like Medical Care and JAMA and start to make them very serious outlets for health economics, because to Chuck's point, health economics is not going away.
So just a quick add to that, if you do have something that does fit in the HSR journal, you can put in, typically you recommend some reviewers. They won't always take them, but that's a starting point to get it reviewed right. And the second thing is we can all write letters when we see a bad article in the journal, write a letter to the editor and say, that stunk and here's why, so it will help us colonize the editorial boards. Next question, there was one over here. Wow, we've completely, okay, yes, Jose.
Hi, thank you. There's one thing you haven't mentioned, which is working with them, like having co-authors, which are not economists, but MD. Yeah. My main field is economic history, and I found really helpful to work with historians, right? So there are those guys working for 10 years, looking in this database, and then you can go there and they open the boxes and they have this wonderful data set in this obscure archive in the basement of a cathedral. So I think one way to colonize or to write this sort of easy paper would be to just, find a friend, which is an MD, which is willing to learn some economics, and he knows all the facts, and he doesn't know how to put them together. And then, he just provides the fact, you explain the trade-off, and then you both can benefit and publish in both type of journals.
Yeah, I think that's right. And I think that physicians intrinsically are more collaborative than we are. The nature of medicine is fundamentally more collaborative than the nature of economics. So the impediment to collaboration is often us, because we start to say, oh, we've got to add these 16 regression coefficients into table 1 because that's how we demonstrate rigor. But again, that's what gets you rejected at medical journals. They're trying to make the journal accessible to a practicing physician. Right. But I think that they're open to us collaborating with them.
Very much. What you can do when you're working with physicians is not try to add 16 more variables in the equation, but get in at the design phase of the study they're doing that's funded by the NIH and put in those 1 or 2 key questions that makes us a brilliant insight into something we don't know anything about. Why do people choose to get a diagnostic test for some genetic disease or not? There's a lot of things we can learn about human behavior if we can answer those types of questions. And if you can just get 1 or 2 simple questions to the patients involved in a physician study, you can nail some of those questions. So you got to get in early with them, which means they have to trust you. So you got to maybe do a couple of dumb things with them first. But that would be my advice about how to work your way in with that crowd, and then pick out that bing little small touch you can add to their study design and let the NIH pay for it, so that Herb and his friends at HCPR or AHRQ now don't have to cover that. Okay, well, we will wrap up. There will be plenty of opportunity for carrying this on and later discussion with these people. And again, thank you to Karen and Amitabh for really tremendous presentations.